Today I'll be good evening everybody. Today I'll be speaking imaging of encephalitis. So encephalitis is a diffuse inflammatory disease of the brain caused by variety of agents like toxins, and most commonly in Indian setup is the viruses which is responsible for causing encephalitis. Usually the outcome of a viral encephalitis is usually unfavorable. It leads to morbidity, mortality, or severe developmental delays, etc. And some of the encephalitis caused by virus like herpes simplex encephalitis, with the introduction of acyclovir treatment early, the morbidity can be reversed. And herpes simplex encephalitis is one of the most common cause of viral encephalitis. So, how the patient presents how the clinical presentation and how the patient presents is that he will have a fever, headache, focal neurological deficits, hemiparesis, generalized or focal seizures, altered or decreased level of consciousness. Usually the clinical findings are very important in diagnosis of viral encephalitis, because the most of the early imaging features like CT and MR are usually negative. So the clinical presentation is very important, and usually the diagnosis is established by polymerase chain reaction of CSF, the CSF analysis for protein, and also for elevated IgM antibodies, and also for mapping of the various virus. The CSF study is very important, and also the last but not the least, the appropriate imaging is important. So imaging is also important for follow-up of patients of viral encephalitis. So many of the patients have similar presentation and imaging features. So it's very difficult to distinguish between the type of virus, but we can give a broad diagnosis of viral encephalitis. The most common causes are herpes simplex virus, which is the most commonly diagnosed virus and treatable cause of viral encephalitis. The rest are Varicella-zoster, Epstein-Barr virus, influenza virus, Cytomegalovirus, which occurs in immunocompromised patients. So these are the different types of virus. We have a broad heading like herpes virus family, which is a DNA type virus. We have herpes simplex virus, which is an adult or a sporadic type of viral encephalitis. The herpes simplex 2 is the neonatal herpes, which is caused by in the neonates due to infected birth canal. So the Varicella-zoster virus is also caused due to this is also a DNA type of virus, which includes in the included in the herpes families. The biggest of encephalitis, Epstein-Barr virus, Cytomegalovirus, the human herpes virus 6, herpes simile. These are all herpes families. Next, this is a different type, is the Eastern equine encephalitis, and Flavivirus encephalitis is the RNA type virus, and Japanese, which is the most commonest, is the Japanese encephalitis or West Nile fever, which occurs in the Indian subcontinent, in the Southeast Asia, which we encountered in India. Murray Valley virus, then HIV, then Japanese encephalitis leading to progressive multifocal leukoencephalopathy in AIDS patient. Nipah virus, St. Louis encephalitis is common in the United States of America. The Rabies encephalitis, which is very sporadic and is caused by infected bites of the dogs. The measles infection, which leads to chronic prolonged infection, may lead to subacute sclerosing panencephalitis. These are the type of virus which we infected. There are more than 70 virus which infects the human, and each type is very difficult to distinguish. Only DNA analysis of CSF for the viral, and also some of the imaging features are diagnostic of specific type of virus. So why imaging of viral encephalitis is important is that first is the follow-up of patient and then the diagnosis. But there are some criteria we should remember, is just early imaging with CT scanning or radionuclide study may also reveal normal findings. So CT and radionuclide studies usually in the early course of the disease may be normal, and CT scan may reveal abnormalities only after the patient is 3 to 5 days after the symptoms onset. By the time the patient will be in the coma state or will be in the high morbidity status. So when typical findings of HIV, HSV, herpes simplex encephalitis are observed on CT scan, they are associated with severe brain damage and a poor prognosis. So early diagnosis of viral encephalitis by CT scan is not possible. So imaging only is helpful during the course of the illness and also in the follow-up course of the illness. So early, whenever you are diagnosing viral encephalitis, the early and foremost important is the clinical symptoms and the CSF DNA study and also the polymerase chain reaction for identifying which type of virus. So imaging has a role, but not in the early stage of viral encephalitis. So nowadays the MRI is a preferred modality for evaluating the brain in encephalitis. However, even in MRI also, there are in the early course of the disease, like in 10% of patients in the early course of the disease, MRI results may be negative. And one thing is that you should remember that negative MRI does not rule out herpes simplex encephalitis or a viral encephalitis. Therefore, the therapy should be instituted. If clinically there are findings of encephalitis, then the therapy should be instituted and laboratory tests to be done to exclude the diagnosis. And normal CT results and cerebrospinal fluid studies in presence of abnormal MRI and electroencephalogram findings indicate that MRI is more sensitive. So MR modality is more sensitive in diagnosis of viral encephalitis rather than CT. I'll give some examples. So the most commonest cause of viral encephalitis is herpes simplex encephalitis. This is the most commonest cause of fatal, sporadic, fulminant and necrotizing viral encephalitis. Usually it acts due to reactivation of the virus in the ganglion of the brain. When the patient gets immunocompromised or a fever or is having morbidity, the virus gets activated and cause the diseases. Usually there are two types of herpes simplex encephalitis. One is neonatal herpes encephalitis, which is caused by herpes simplex 2 virus, which occurs in the early neonatal period or 1 or 2 months after the baby is delivered. Then the second is the childhood or adult herpes encephalitis. It's the most sporadic form and fulminant infection, which can be treated by acyclovir treatment. It gives dramatic response to the acyclovir treatment. In the immunocompetent adult patients, the herpes simplex manifests as bilateral asymmetrical involvement of the limbic system, medial temporal lobe, insular cortex, and inferior medial frontal lobes. So in the herpes simplex virus, the commonest involvement is the medial temporal lobes, insular cortex, and inferior medial frontal lobes. The basal ganglia thalamus are spared in the herpes simplex encephalitis. In the immunocompromised patients, there may be widespread cortical involvement, even brainstem and cerebellar involvement is also there. And if there is a development of petechial hemorrhage and cystic encephalomyelitis, it indicates a severe form of herpes encephalitis. And it's associated with bad prognosis. This is the example. I will show you these two MRI cases. This is a FLAIR MRI sequence. You will see that there is extensive high signal abnormality in both the temporal lobes involving the medial temporal lobe, and usually they are not symmetrical abnormality. One side, right side is more than the left side. And also there is you feel that there is an inferior medial aspect. The posterior and inferior medial aspect of the frontal lobes are also involved, and the disease is more prominent in the right temporal lobes. And always we do a contrast examination to see whether there is associated meningitis. So in this patient, the patient has got encephalitis, and also in this coronal post-contrast T1 fat sat images, you can see there is meningeal thickening and enhancement. So this patient indicates the patient is having encephalitis plus meningitis. So he is suffering from herpes simplex meningoencephalitis. So comparison is of CT and MR is very important. So usually we should not by CT. There are a lot of limitations in doing in encephalitis examination. See in this patient, the edema is only restricted to medial temporal lobe. We see that we will in the CT sometimes. In most of the cases, in the early course of disease, we say it's a normal or it's a mild abnormality involving only medial temporal lobe. But whereas we do MRI, we see that the extensive abnormality is there. See, whole of the temporal lobe is involved, and also the whole of the frontal lobe is involved, and the medial aspect of the temporal lobe is involved. This is a case of herpes simplex encephalitis where MR is very important, and CT should not be done in cases of encephalitis. Only in the delayed cases we can there will be some information by CT. So coming to the MRI, one thing is that the most sensitive MR modality, MR imaging for herpes simplex or encephalitis is diffusion weighted MRI. Next comes the flare images. Next comes the T2 and proton density weighted images, and T1 weighted images are only is used for detecting complications like petechial hemorrhage or encephalomyelitis, like that, and gradient echo images is used when there is a concomitant hemorrhages. There will be blooming and gradient echo images. See, in this patient you can see that the flare images, you can see that there is very slight abnormality in the temporal lobes. The frontal lobes are not involved. So we can say that the disease by if you are looking only by flare images, we can say that disease is restricted to temporal lobe. But if you do a diffusion weighted MRI, we can see that the abnormality is not only restricted to temporal lobe, but there's also frontal lobe involvement. So the disease is more the disease is widespread and involving two lobes. So diffusion weighted MR imaging is a need, and it should be done in all patients of encephalitis patients, and it's more sensitive in detection of the abnormality. And you should always remember the sensitivity, the hyperintensity in diffusion weighted images is not like an acute infarct. It will be faintly hyperintense or slightly hyperintense. It will be not like an infarct where it will start like a blooming, where you can see by just by scrolling we can see the abnormality without changing the window. We can say that there's acute infarct. But in these cases like encephalitis, there will be very little cytotoxic edema, so the the diffusion weighted image there will be slightly hyperintense. So coming to the herpes simplex encephalitis, we can see that axial T2 weighted image. We can see that the medial temporal lobe is involved. There is only one asymmetrical involvement of the right temporal lobe, and there is the edema is extending to the insular cortex and frontal operculum. And this is the diffusion weighted images. We'll see that the abnormality is restricted to medial temporal lobe. There's asymmetrical involvement, unilateral involvement, medial temporal lobe, and there's also involvement of insular cortex. So this indicates herpes simplex encephalitis. So as I told you that T1 weighted images are only in detection of complications, which will be very helpful. This is a patient where we can see the hyperintensity along the insular cortex. There's a hyperintensity which indicates the petechial hemorrhages in cases of herpes simplex encephalitis. There's another patient which is a very high severity. We can see that there's cystic encephalomyelitis in the temporal lobes, and the right temporal lobe is involved, and we can see that the gyriform hyperintensity which contributes to the petechial hemorrhages in cases of encephalitis, which indicates that the findings of petechial hemorrhages indicates a grave prognosis and a very bad prognosis. This is a patient. I will show you the examples where in the CT and MR, in the early phase of the imaging, we can see slight edema in the occipital lobes, whereas after 2 months of imaging, we can see that there is an cystic encephalomyelitis this is the cystic encephalomyelitis developing in the parieto-occipital lobes. So the CT and MR is also used for follow-up of patients of encephalitis. Now coming to the herpes simplex 2 virus, it's called as neonatal herpes simplex encephalitis. It's caused by the vertical transmission of infection from passage from birth canal with diffuse cerebral involvement, occurs first months after the birth, and changes are typically diffuse. So it's very difficult to distinguish the abnormality because there's also normal immature myelin. Both normal immature myelin and herpes simplex encephalitis, the brain involved, will have hyperintense signal on flare and T2 weighted MR imaging. And you should always remember that the herpes simplex 2 virus and herpes simplex 1 virus, the involvement will be different. In the medial temporal lobe and inferior frontal lobes are spared in herpes simplex two virus, and also hemorrhage is also uncommon. And restriction diffusion and diffusion weighted MRI is demonstrated in approximately half of the patients, which tends to be diffuse and bilateral. So this is the herpes simplex 2 encephalitis. So you should be very careful in interpreting the MR images, because in most of the cases in the early features, the MR features may be negative. It's like this patient, there is very slight abnormality. You can see that the asymmetrical hyperintensity in the thalamus. And we do always, in encephalitis image, we do always a diffusion weighted imaging. We see that there is asymmetrical hyperintensity in the thalamus, and also parieto-occipital lobes. There's also involvement where which in the FLAIR images which we can't identify. See the abnormality in the diffusion weighted images. There's also diffuse cortical involvement in the occipital lobes, parieto-occipital lobes. Also frontal lobes are also involved, and ADC maps demonstrates corresponding hypointensity. And always, whenever we can do a MRS sequence, MR spectroscopy, where we will see that the lactate peak. There will be, if you do a MRS at 144 ms, we see that the lactate peak downward, and MRS at 35 milliseconds, we see the lactate high peak. And there is also increased glutamate and glutamine peaks. So coming to the next virus is the Varicella-zoster virus. This is also one of the cause of viral encephalitis, which we encountered in children. So it represents a group of which involves the small and large CNS arteries caused by inflammatory process involving the media and vascular endothelium. So adventitia and media are involved by the Varicella-zoster virus. And in any cases of children and neonate, if you are finding arterial ischemic infarcts, that too occurs in weeks, and arterial ischemic infarct, we should always suspect Varicella-zoster infection. In children, the Varicella-zoster vasculopathy is responsible for 30% of all arterial strokes and often occurs weeks or months after Varicella-zoster infection. So MRI, coming to the MRI, is the cortical and deep abnormalities involved in the gray and white matter lesions, gray-white matter lesions related to ischemic lesions. So because of the medial and large arteries involvement, there will be ischemic changes in the brain parenchyma, which will involve the gray-white junctions and also cortex. And sometimes they affect the spinal cord, causing infarction. About 70% patients have vascular abnormalities in studies. So that is the segmental arterial constrictions followed by post-stenotic dilatation, creating a bleeding appearance, and occlusions may also be seen. And complications of Varicella-zoster vasculopathy include cerebral aneurysms and dissections. So this is a case of Varicella-zoster vasculopathy. We can see that the white matter of the FLAIR images, we can see that there is in the center, in the anterior centrum semival, there is a high hyperintense signals. There's also cortical gray matter involvement, and also at the junction of gray and white matter involvement, we see that ischemic changes. These are all the cortical, subcortical, and gray-white matter junctions we can see in the ischemic changes. This indicates, and in a children, this indicates Varicella-zoster infection, encephalitis. So if you do always in a cases of encephalitis, you do a dedicated 3D TOF MRI. See, for example, in cases of Varicella-zoster vasculopathy, we'll see that there is arterial occlusion. See that there's high-grade narrowing of the right middle cerebral artery at the proximal segment, and also the peripheral branches are also attenuated. We can say that this is due to Varicella-zoster vasculopathy and arthritis. We can see ischemic changes in the right posterior centrum semival and also subcortical white matter. So always in cases of encephalitis, if there's a patient of herpes simplex encephalitis, we see that TOF will be normal. But whereas in patient of Varicella-zoster encephalitis, we can see that there will be occlusions, arterial occlusion. Here we see that there is a complete occlusion of the M1 segment of the right middle cerebral artery. A1 segment is also occluded. There's also moderate to severe narrowing of the left M1 segment of the middle cerebral artery. The anterior cerebral artery is also high-grade narrowing, and we can see the ischemic changes in the central semiveil. So coming to the other type of virus which affects the brain is the Epstein-Barr virus. So it's the underlying pathology of infectious mononucleosis, so which is a benign self-limiting disease. And neurological symptoms have been described and comprise seizures, polyradiculomyelitis, transverse myelitis, encephalitis, and cranial nerve palsies. So in the Epstein-Barr virus, only the CNS is involved in 1 to 6% patients. The lymph nodes are involved. The cerebral, subcortical, and periventricular white matter, including deep gray matter, are preferred compared with cerebrum and brainstem. Those the cerebral, subcortical, and periventricular white matters are involved. And we can see solitary or multiple circumscribed masses or infiltrated growths are also seen. So in these patients, we can see that abnormality. This is a case of herpes simplex encephalitis. Always T1 MRI is useless. T1 weighted, we can't see any abnormality, whereas in T2 weighted MRI, we can see that the faint abnormality involving the splenium of corpus callosum. Whereas if you do another FLAIR images, we can see that in spite of abnormality in the splenium of corpus callosum, the parieto-occipital, the posterior-parietal and occipital lobes, we can see that hyperintense signal intensity. So always the ADC images are the diffusion weighted images are important. We can see that the splenic abnormality is very diffuse, and also we can see that the cortical abnormalities in diffusion weighted images. So, and we do a ADC map, we see that the abnormality involving the splenium of corpus callosum, and T1 weighted post contrast gadolinium, there is no enhancement. So always diffusion weighted images and FLAIR sequences are good in detecting the edema or inflammatory changes by encephalitis. So I already told it can herpes simplex encephalitis can also appear as a circumscribed or infiltrating mass, and sometimes this may be very difficult to differentiate from a toxoplasmosis. You can see that a ring enhancing lesion with perifocal edema in the involved the occipital lobe, and also if you do a T2 weighted images, we can see that there is a petechial hemorrhage around the lesion, hemosiderin rim, and in the left occipital lobe also there is involvement. We do a gradient echo images. We can see that nicely that the lesion is getting involvement. The lesion is demonstrating hyperintense signality, and also there is diffuse edema. So always this is what I was showing. This is a PCR CSF study. So I was always saying the MRI is needed for follow-up of patients. So this is a PCR of Epstein-Barr viral encephalitis. We see that the parieto-occipital region bilaterally is regressed. These are the abnormalities which are regressing in the follow-up MRI after 2 months, whereas the polymerase chain reaction of CSF study will demonstrates Epstein-Barr virus. So in sometimes the MRI will show that there is a corresponding decrease in there is an improvement in the patient. So this is the patient. We see that another patient after 2 months, we see that there is abnormality involving the parietal occipital lobes. After 2 months, we do a follow-up MRI of the FLAIR images which demonstrates negative. There's no abnormality, whereas the CSF study indicates that the Epstein-Barr virus is still present. So sometimes the follow-up MRI is very important in cases of encephalitis to see the abnormality, whether a patient is regressing or progressing, or there is a significant resolution of abnormalities. So coming to the another one virus which affects the brain in the neonates and profound immunosuppressant patients is the Cytomegalovirus. CMA virus is the most frequent prenatal infection known as congenital CMA infection. Also it occurs in the neonates. So in the CT brain we will see intracranial calcification, particularly thick and chunky in the germinal matrix and periventricular regions with faint and punted basal ganglia calcifications. White matter low density regions we find, and there will be ventriculomegaly, cerebral atrophy, and destructive encephalopathy, neuron migrational disorders. These are all which usually occurs in the in vivo fetus, it gets infected by Cytomegalovirus, and these are the abnormality we find. And MRI also demonstrates microcephaly, migrational abnormalities, lesioncephaly, pachygyria, and schizencephaly. The white matter lesions are predominantly in the parietal and posterior white matter involvement with spared rim immediately periventricular and subcortical areas, the ventricular megaly and subarachnoid space enlargement. So complications include CME, encephalitis, and hydrops fetalis. So always cytomegalovirus encephalitis will have a distinct meningitis or encephalitis will have distinct subependymal contrast enhancement. So there will be enhancement of the subependyma around the lateral ventricles. This is the imaging. This will classically imaging features of cytomegalovirus encephalitis. Because of from the blood vessels, it gets into the subependyma, where on contrast enhanced MRI it demonstrates subependymal enhancement. That is the encephalitis stage. These are the complications of CME encephalitis, where we see there's chunk and gyriform calcifications in the periventricular and basal ganglia regions. There's also hydrocephalus. There's also diffuse white matter abnormality. This another patient we see subcortical and diffuse gyriform calcifications were scattered throughout the brain parenchyma. That indicates CME infection in the in utero. So post neonate, this is a patient with neonate. We can see that there is a bilateral open lip schizencephaly communicating with the ventricles. There's also there's also absence of septum pellucidum and corpus callosum, and there's a large central defect. This is another patient's MRI is done titubated axial, titubated emergent deviate states, the thick, smooth gyri with loss of sulcations, and there's diffuse white matter abnormalities. The ventricles are enlarged. Here you can see that there is also thick, broad cortex, which indicates pachygyria or cortical dysplasia. In this case, we can see that there's polymicrogyria in this area. So this all indicates that the patient CME encephalitis in utero or after the neonate. So this is the patient after the birth, he got infected. We can see that there's a diffuse white matter abnormalities. I told you that there's the subcortical and periventricular white matter abnormalities and the anterior and posterior location. And we do a follow-up MRI after 6 months, which indicates that the anterior portions are decreased, whereas the posterior portions are persistent, but the signal abnormality is less. So there is some amount of improvement, some amount of radiological improvement in this patient. So coming to another very important virus is the human herpes virus 6, which is called as which also causes encephalopathy, but we have to differentiate from herpes simplex encephalitis, because the herpes simplex encephalitis is it's a very severe fulminant viral infection, and both involve the mesial temporal lobe. The medial temporal lobe is involved. Herpes simplex virus is sensitive to acyclovir, but herpes simplex virus 6 encephalopathy is resistant to acyclovir administration. So how to differentiate is that there's a transient abnormal signal intensity in the mesial temporal lobes in patients with herpes simplex 6 encephalopathy, but persistent abnormal signal in both mesial temporal lobes and extratemporal regions in patients with herpes simplex encephalitis. So in herpes simplex 6 virus, you see only transient abnormality in the medial temporal lobe, which will be varying with the time. Whereas in herpes simplex virus 1 encephalitis, there is a persistent abnormality, and it will extend outside the mesial temporal lobes in the extratemporal regions. This is the case of herpes simplex 6 associated encephalomyelitis. We can see that in the day 2, you can see that the abnormality is limited to the mesial temporal lobe, hippocampus gyrus. You can see the very bright signal on the ADC and in the diffusion, and there's corresponding hypointensity on ADC. Whereas the abnormalities have not progressed. This is a patient in the R22. If there is herpes simplex virus, the abnormality should have progressed to the temporal lobes or inferior medial limb, but the abnormalities are very transient and they are decreasing. So that indicates that this is a patient case of herpes simplex 6 encephalitis. See, on day 22, the abnormalities have slightly decreased. Even the diffusion is not much ungraded, and on day 45, the whole of the abnormality has been reversed. So herpes simplex 6 virus causes transient abnormalities only in the mesotemporal lobes, whereas herpes simplex virus causes very extensive abnormality in the temporal lobes, and usually it's a fulminant course of infection. And usually hemorrhages don't occur in herpes simplex 6 associated encephalitis. So coming to the different type of encephalitis, which we have dealt with herpes simplex encephalitis, the types of virus which are all DNA virus. Now we are coming to the RNA type of virus, which have a characteristic involvement that they involve only the basal ganglia and thalami, which usually involve basal ganglia and thalami. And there are 70 viruses, which human virus, 70 Flavivirus, which infects the human, and usually acquired through bite of infected mosquito or tick. So the most important of all is the Japanese encephalitis virus, which is in the Asia, chikungunya virus. The West Nile virus is also Middle East, North America. The tick-borne encephalitis virus, Murray Valley encephalitis virus is most common in the Australia, New Zealand, and in the United States of America, the St. Louis encephalitis virus, the Rosia virus in Brazil. So these are the geographical distribution of Flavivirus. This will show you in India and Asian subcontinent. We can see that the Japanese encephalitis is more, and even in the Punjab and northern ports and south, we can see that the West Nile virus is more. This is America. We can see that America, where there is St. Louis encephalitis, the predominance of St. Louis encephalitis. So Flavivirus have a geographical distribution of disease process. In Australia, we have more of Murray Valley encephalitis, but all the Flavivirus have the predisposition to involve basal ganglia and thalamus. And in the Indian context and Southeast Asia, we have Japanese encephalitis and West Nile virus. So Japanese encephalitis is the leading cause of acute meningoencephalitis affecting children and adults in the world. So Japanese encephalitis is endemic in Indian subcontinent, particularly northeast states of Assam. And bilateral thalamic and substantia nigra involvement of the midbrain is classical regardless of CT or MR imaging. The other areas may also be involved, like midbrain, pons, cerebellum, basal ganglia, cerebral cortex, spinal cord, and imaging within 3 days may not reveal hemorrhagic lesions. So always, I've already told, the MRI should be repeated after 1 week, 2 weeks to see the disease is progressing or there's regression of lesions. So this is a patient of Japanese encephalitis. We see that there's bilateral thalamic involvement. This is FLAIR images, bilateral thalamic involvement, and there is focal areas of hemorrhage in the left thalamus. So we do a diffusion weighted image, and we can see that there is asymmetrical hyperintensity involving the thalamus, and also it's for a follow-up of assessment of lesions. So as I already told, that the diffusion weighted images are more sensitive in detection of abnormality. This is a Japanese encephalitis where there is a thalamic involvement. So coming to the West Nile encephalitis, which is also common in the Indian subcontinent, we can see that this is a patient of 55 years old with West Nile virus encephalitis. So we can see that the pontine gray matter is involved, the dentate nuclei are involved. This is the substantia nigra of midbrain. So Japanese encephalitis and West Nile encephalitis imaging features are almost similar. So sometimes only by CSF analysis we can differentiate the type of virus. Both are Flavivirus and both have a predisposition for involving the MRI in the typical distribution. We can't differentiate by imaging which type of virus, but we can indicate that this is a Flavi group of virus, and most commonest is Japanese encephalitis. The substantia nigra is involved in the midbrain, the red nucleus, the globus pallidus, and and hypothalamus also involved. So this is a case of benign encephalitis. So these are the some broad imaging features like herpes simplex, which includes temporal and frontal lobes. Japanese encephalitis, as I told, is a Flavivirus. Japanese encephalitis, West Nile virus, they are all Flavivirus, RNA type of virus, which involve the basal ganglia, thalamus, brainstem, and cerebellum. The West Nile virus involves the deep gray matter, mesial temporal lobe, brainstem, cerebellum. The rabies virus, which is common in Indian context, it also involves the basal ganglia, brainstem, and temporal lobes. The chikungunya virus, cingulate gyrus, and limbic system. So coming to the most important in Indian context is the dengue fever, which causes dengue hemorrhagic leukoencephalitis, so which are very common in Indian subcontinent. So dengue fever is the most common viral infection worldwide, especially in tropical regions. Presentation of dengue viral infection is often unpredictable, varying from clinically silent infection to uncomplicated dengue fever, dengue hemorrhagic fever, and severe fulminant dengue shock syndrome. A neurological manifestation is a dengue hemorrhagic leukoencephalitis. I will show you one example. This is the patient with the dengue fever, dengue encephalitis. You will see that there's involvement of the basal ganglia. Multifocal flare hyperintense signal intensities are noted in the gray-white matter junctions of the temporal occipital lobes, also in frontal lobes. So this is the initial imaging. Initially at the time of imaging, we do a gradient echo image to see whether there's any bleed. There's no bleed absolutely anywhere in the brain parenchyma. But after follow-up of 3 days, we can see that there is a blooming on gradient echo images involving the left lentiform nucleus, also in the cortical and subcortical region of parieto-occipital lobes and temporal lobes. So this indicates hemorrhage within the encephalitic lesions, which indicates the hemorrhagic encephalitis, which is a very poor prognosis. So there's another patient with dengue encephalitis. We should always know that dengue is a rhabdovirus, but the imaging features are almost like a Flavivirus, where there is involvement of thalamus and basal ganglia. There's diffuse bilateral thalamic involvement we see in the T2 weighted image. We do a gradient echo images. We see a blooming in the thalamus, and diffusion restriction appears hyperintense. And after doing a SAS T2 image, we can see that there's also brainstem and cerebellum involvement by the dengue virus, which indicates a very bad prognosis. So rabies encephalitis is also another type of encephalitis. It's one of the oldest communicable diseases known to man. It's acute infection involving CNS in humans and other mammals caused by RNA type of rhabdovirus. The transmission is through bite of dogs and wild animals. And rabies virus presents in encephalitis and paralytic forms. So in rabies encephalitis also we see increased T2 signals, prediction for increased T2 signal and prediction for basal ganglia, thalami, hypothalami, brainstem, limbic system, and spinal cord, as well as frontal and parietal lobes. In paralytic rabies, we see there's involvement of spinal cord and medulla. However, the imaging does not distinguish between classical encephalitis or sporadic forms. So in rabies encephalitis, the signal abnormalities are very minimal on pair images. We can see in this patient like there is hyperintensity in the globus pallidus and thalamus bilaterally. This is a proton density involvement. There is involvement of caudate nucleus and also globus pallidus and putamen. The brainstem is not involved. So this is the case of rabies encephalitis. So on all encephalitis, we come now one of the most commonest acquired infection is the AIDS infection. So the retrovirus encephalitis is also very important. So retrovirus is a single-stranded positive sense RNA virus with a DNA intermediate host, and as an obligate parasite targets a host cell. The CNS manifestation of HIV neuroaids occurs secondary due to wide range of neurodegenerative, infectious, inflammatory, and neoplastic process. So what are the direct consequences of HIV viruses? HIV-associated dementia. is also known as AIDS dementia complex. Next, AIDS vascular myelopathy, opportunistic infection, toxoplasmosis, cytomegalovirus, fungal infection, cryptococcus, candida, aspergillus, and tuberculosis, neurosyphilis, and progressive multifocal leukoencephalopathy and bacterial. So whenever nowadays the cases of AIDS, encephalitis like HIV encephalitis or encephalopathy is important, as there's as the prognosis is bad when there is a HIV encephalitis. So this is a direct infection of the brain by HIV virus, and usually it has been classified as HIV-associated neurocognitive disorders. All AIDS dementia complex, HIV-associated dementia, HIV encephalopathy, HIV encephalitis are all included under AIDS hands, called as HIV-associated neurodegenerative disorders. The radiological features are the diffuse and symmetrical cerebral atrophy, out of proportion in keeping with the age of the patient. There will be central cerebral atrophy, and it's out of proportions to the patient age. And there will be symmetrical periventricular and deep white matter hypoattenuation. So on the MRI also the same findings we find: symmetrical periventricular and deep white matter hyperintensity with relative sparing of the subcortical white matter and posterior structures. So always HIV encephalitis should have to be differentiated from a progressive multifocal leukoencephalopathy, PML. This HIV encephalitis and PML should be differentiated. So HIV encephalitis has a good prognosis compared to PML. So in HIV encephalitis, there will be sparing of subcortical white matter and posterior structures. It will be confluent or patchy enhancement. There will be no mass effect or no enhancement. So this is a patient of HIV encephalitis or encephalopathy. We do a FLAIR images. We can see that there is a diffuse symmetrical white matter involvement involving the frontal and parieto-occipital lobe. See that there is a diffuse involvement. The subcortical U fibers, these are the subcortical U fibers, are not involved. And you see that the ventricles are very prominent compared to the cortical sulci. There is diffuse central atrophy where there will be ventricular prominence out of proportion to the sulcal prominence. This is another patient. We can see that there is a ventricular prominence out of proportion to the sulcal prominence, and there is a diffuse white matter, subcortical and periventricular abnormalities, and these are symmetrical. These are symmetrical. There is no involvement of the subcortical U fibers. These are the subcortical U fibers. They are not involved. This is a patient with advanced HIV disease and encephalitis. We see that the diffuse abnormality is extending to the centrum semilunar. We can see that how symmetrical abnormality we are seeing in HIV encephalitis or encephalopathy. So the diffuse abnormality can involve the centrum semilunar, pons, cerebellum, and thalamus. Now HIV encephalitis should have to be differentiated from progressive multifocal leukoencephalopathy. How to differentiate is very important by imaging. The progressive multifocal leukoencephalopathy is a fatal subacute progressive demyelinating disease seen in a person with impaired cellular mediated immune response. So PML occurs in patients with immunodeficiency syndrome. PML develops in 5% of all patients with AIDS, and it's usually due to reactivation of Japanese encephalitis virus. So progressive multifocal leukoencephalopathy is a bad prognosis in patients of AIDS patient, and MRI has great sensitivity in detecting the lesion. On MR we find hyperintense and typically involving the periventricular subcortical white matter, but there will be involvement of subcortical white matter. In the PML there will be involvement of subcortical white matter, which demonstrates scalloped lateral margin. I'll show you the example. And there will be multifocal distribution, and it's bilateral but asymmetrical. In HIV encephalitis it is bilateral symmetrical, but in PML it is bilateral and asymmetrical. So when there is a posterior fossa involvement, there is also involvement of the supratentorial structures, and in 10% the lesions are confined. See, this is the example of a PML. You know that fluid attenuation inverse series, patients with visual defects, aphasia, and balance problem. You can see that there is a asymmetrical involvement. First, we should see that there is asymmetrical patchy involvement in the brain parenchyma. Asymmetrical patchy involvement. There will be multifocal distribution. there is a white matter abnormality involving the parieto-occipital lobes, and there you can see that the subcortical U fibers are involved here. So, and progressive leuko, and this is diagnosed as progressive multifocal leukodystrophy. And you should, whenever you diagnose PML, you should always give a CSF fluid analysis for Japanese encephalitis virus, but in this case was negative. This is another example of a PML patient. Here there is a diffuse periventricular and subcortical white matter involvement. There is asymmetrical involvement. See that there is a lateral scalloped margins. Here also we can see that the margins are laterally scalloped. This indicates there's involvement of subcortical white matter. There will be no enhancement or no mass effect. If there is a mass effect and enhancement, this indicates a poor prognosis. So this indicates PML. Now coming to the measles virus, which is one of the commonest cause of encephalitis. There are three types of neurological complications that occurs with measles virus. One is the acute post-infectious encephalitis. Next is the acute progressive infectious encephalitis. That is third is subacute sclerosing panencephalitis. The acute post-infectious encephalitis is commonest and occurs 2 to 14 days after the appearance of rash. So this occurs due to direct attack of the virus in the brain, whereas subacute sclerosing panencephalitis occurs 3 to 10 years after virus, usually at 10 to 11 years of age or 10 to 13 years of age this occurs, and is persistence of virus in the brain cells. So acute disseminated encephalomyelitis, as the name suggests, is a monophasic acute inflammation and demyelination of white matter, typically following a recent viral infection or vaccination. Gray matter and basal ganglia is involved, and also sometimes the spinal cord is also involved. You can see that there is diffuse cortical gray matter involvement, white matter involvement, and also thalamus involvement. There's no enhancement on the contrast. So this is a case of measles disseminated encephalomyelitis. Then coming to the subacute sclerosing panencephalitis, which is due to persistence of a virus in the brain for a long time, and it usually occurs in the childhood and early adolescence due to persistence, and the diagnosis is based on clinical findings, EEG results, and the titer of measles antibodies in the CSF and serum. The parieto-occipital region of the brain is the most frequently and severely affected, and involvement is generally asymmetrical. So there is involvement of the parieto-occipital region of the brain, and there will be asymmetrical involvement in subacute sclerosing panencephalitis. So this is a patient T2-weighted BMI. You see that there is a white matter abnormality involving the posterior aspect of the brain and periventricular subcortical white matter. But you can see that the abnormality is in the posterior aspect of the brain, and also there is asymmetrical involvement. And there is no mass effect or no enhancement. And there will be also the atrophic changes are also not there. So by CSF analysis of measles antibodies, we can definitely say that this could be a subacute sclerosing panencephalitis. Now, of all the infective encephalitis we have discussed, they are all infective encephalitis caused by viruses and other organisms. Now, this one encephalitis which occurs, which is a non-infective condition called as limbic encephalitis, which is not due to infection, it's due to non-infective condition. Limbic encephalitis is also known as autoimmune limbic encephalitis, is due to autoimmune mediated inflammation of the brain, typically involving the limbic system. So the mesial temporal lobes is involved, and limbic encephalitis is broadly divided into two types. One is the paraneoplastic limbic encephalitis, another is the non-neoplastic autoimmune limbic encephalitis. So there is, and we should always differentiate limbic encephalitis from a herpes simplex encephalitis. So this is a non-infective encephalitis, whereas herpes simplex encephalitis is an infective encephalitis. The symptoms are psychotic symptoms, which will be prodromal symptoms, which occurs over a course of time in limbic encephalitis, whereas in herpes simplex encephalitis, the symptoms are limited to 1 week or few days. The most commonest involvement are mesial temporal lobes and limbic system, typically manifested by cortical thickening and increased due to signal intensity of the regions. Bilateral involvement is the most commonest, and Although they are asymmetrical involvement, lateral temporal lobes and insular are not involved. The herpes simplex virus involves the lateral temporal lobe and insular cortex. The basal ganglia are sometimes frequently involved. The presence of hemorrhage and susceptibility weightage image is in favor of diagnosis such as herpes simplex encephalitis, which has a very similar imaging features to limbic encephalitis. See this by seeing the images we can see that the pattern of involvement is the mesial temporal lobes and medial temporal lobes, and there's also involvement. We can see that this we can give both differentials as limbic encephalitis and herpes simplex encephalitis as there's involvement of medial temporal lobe. But there's no involvement of the extratemporal lobes. There's a very classical clear-cut boundaries. The extratemporal regions are not involved. It's a very classical clear-cut boundaries, and there's bilateral symmetrical involvement here. Whereas in herpes simplex encephalitis, there will be asymmetrical involvement and there will be extratemporal involvement. Whereas here it is due to symmetrical involvement. So it indicates limbic encephalitis. So this is the cingulate gyrus and insula is also involvement. You should not get confused with herpes simplex encephalitis. So most of the limbic encephalitis is usually secondary due to paraneoplastic syndrome. The patient may be suffering from lung carcinoma, testicular carcinoma, or autoimmune mediated disease like SLE, systemic lupus, where he develops antibodies to the brain cells and he develops this type of encephalitis. The patient will have a prolonged symptoms from 3 to 4 months. So this has to be differentiated from a viral encephalitis. See in the coronal T2 weighted, you can see that hippocampus, parahippocampal gyrus is involved, but there is a symmetrical distributions, and also we can do a gradient echo images to see that there is hemorrhage. If there is hemorrhage, then we can say that there's a patient is a case of herpes simplex encephalitis rather than a limbic encephalitis. So coming to the conclusion, MRI is a preferred and sensitive modality in diagnosis and follow-up of various types of encephalitis. So MR is only not the modality. MR should always be MRI along with clinical correlation, EEG and CSF, PCR chain polymerase chain reaction, and also MR and CSF study of MR for viral titers, viral antibiotics are employed in the evaluation of encephalitis. And we should know that the CT and MR may be normal in early case of encephalitis. So if the clinician is suspecting encephalitis, the CT may be completely normal in the early stage. MRI in 10% of cases, in cases of encephalitis, MRI may be also be normal. So we should always tell the physicians that in the early course of the disease, the MR signals will not be so. MR may not pick up the early changes of encephalitis. So clinician should always do a CSF study and do a viral titer of the CSF, and also EEG studies, and also clinically how the patient is informed. Only follow-up cases after 3-4 days, the MR may be positive in some cases. These are the references. Thank you.